Suicide is among the leading causes of death in the United States, and there is a critical need for education around suicide. Our goal for this session is to provide an overview of the topic, exploring everything from the scope of the issue and risk factors to signs and symptoms and prevention strategies. To help us with this effort, we have asked Drs. Yeates Conwell and Anna Precht to join us. Dr. Yeates Conwell is a professor in the Department of Psychiatry at the University of Rochester Medical Center. He has served as founding co-director of the UR Center for the Study and Prevention of Suicide and has lectured and written extensively on suicide and depression in later life. Dr. Anna Precht is a clinical psychologist and a senior clinical consultant at McLean's Arlington School, a high school for students with mental health challenges. She specializes in the use of evidence-based treatments, including DBT and CBT. Yeates, let me start with you and ask you to define a few terms that we're going to be using today. Suicide, suicidal ideation, and non-suicidal self-injury. Can you give us working definitions of each?
Sure. It's a real pleasure to be here. Thank you for inviting me. I'm glad to be able to participate. Suicide is the term we use for when there is actually a death that is caused by intentional self-directed behavior. And that's distinct from attempted suicide, which is non-fatal, but intentional self-directed behavior. So that intentionality is the critical aspect of suicide and attempted suicide. Whereas I think you mentioned the third being non-suicidal self-directed behavior. That is a behavior which is self-harming, but is not intended to end one's life.
And there has been a lot of focus on the way we talk about suicide as a society. For example, experts encourage us not to use the term committed suicide. Can you explain the importance of this effort?
Absolutely. So I also want to add, assessing the difference between non-suicidal self-injurious behaviors and suicidal behaviors is absolutely crucial for deciding what intervention to then get into with somebody who's presenting. Because if somebody has cut themselves, for instance, in a non-suicidal way, they need a different kind of intervention compared to somebody who is making a suicide attempt. In terms of the language we use, I believe it's so important in reducing stigma and judgment around behaviors. Suicide has been something that has been not discussed, has been shamed for so long and spoken about in really judgmental language that has led to people feeling worse, more shame, and further disconnected from a community and less likely to seek support when they're struggling. And so when you say the word commit, for instance, this is something that I think is a word that people use all the time. And yet it conjures up an old historical version of suicide being a sin, a crime. People commit sins, they commit crimes, whereas attempting to end one's life or dying by suicide takes out that piece of it. And it seems like a small thing, but I think it adds to a bigger picture in terms of how people are struggling really perceive how others are perceiving them.
Makes a lot of sense. Yeates, do you want to add anything to that in terms of messaging?
Oh, it's so important, and Anna's exactly right. It's everywhere. It's hard to actually be participating in a conversation in which those terms, which we find so potentially problematic, are used, like committed suicide. There are others, like a successful suicide attempt. It's not a success. It's a failure in our ability to help that individual. That term, failed suicide, is another one that we often hear, which refers to a suicide attempt. But again, casting this notion of failure on the individual who's in such pain, and we need to understand that. And it's so important not to stigmatize and further drive underground and this terribly important topic for open conversation, non-judgmental open conversation.
And before we move forward from this topic, I think it's important to talk about some of the common myths and misconceptions about suicide as well. Either of you want to tackle that for us?
Absolutely. I mean, there's so many myths. I'll start with one, that asking somebody if they're experiencing suicidal thoughts will make them have suicidal thoughts or will prompt suicidal behavior. I think people are so scared to talk about suicide. I mean, healthcare professionals, parents, friends, people are scared of it because it is a very scary thing. And at the same time, we cannot be scared of talking about it, because it's by talking about it that we are able to offer the help that people need. And we have to demonstrate that this is something we can talk about, that people can be vulnerable about some of their most painful crises that they're in. So talking about it does not make somebody suicidal. That's one myth. Yeates, you got another?
Oh my, yeah, sure. I would add to that not only does talking about it not make somebody suicidal, it's the opposite, actually. And we'll come more into that, I think. The ability to talk about it can be so helpful to people. Another would be, what's a common one? If you talk about it, you're really not serious about it. You're really not going to do it, right? Or analogous to that, you're just seeking attention if you're talking about suicide. Not the case at all. People who are looking or are in that kind of pain, ideally, they will be able, under the right circumstances, to reach out and to mention something that opens a discussion window about the level of pain that they're feeling, which then can lead to the interventions that can save a life. So to actually talk about somebody who is revealing their suicidal thoughts as a weakness, a selfish kind of approach to things, or that they're actually not serious, is really more a reflection, I think, of our own anxieties that are created when we hear somebody else in that kind of pain. It's a myth. It's not true that when people talk about it, that they're not serious or they're being selfish or it's a sign of weakness at all.
I want to ask you both to help provide some perspective in terms of the scope of the problem. What do we know about the current prevalence of suicide?
Well, we know that it has been increasing, certainly, and staggeringly so. Currently, the prevalence rate, I mean, 50,000 people approximately each year die by suicide in the United States, approximately 700,000 people worldwide every year. And these numbers have been escalating. And for some people, they think, oh, it was the pandemic, and that was the turning point where this escalated. And that isn't the case. We've seen these numbers going up since about 2000, 2001. And then since the pandemic, certainly we've been hearing about the mental health crisis, particularly with young adults, teenagers, and elderly populations. But this has been steadily increasing over the course of the past 20, 25 years.
Yeates, anything you want to spell out in terms of demographics or anything else that we should know about when it comes to prevalence?
Yeah, there's a lot of variability there. While we talk about this public health crisis, which is suicide, 11th leading cause of death in the United States in 2022. And as Anna said, close to 50,000 deaths by suicide. That's reflected also in attempted suicide, where we believe in the United States there's something like 1.6 million attempted suicides a year. Get that, 1.6 million. It's a tremendous public health problem that, by and large, we don't hear enough about because of the stigma we were referring about before. There's a lot of variability, however, in those rates. They change over time, and as Anna said, they're going up, which is in contrast, importantly, to most other developed countries in the world where those rates have gone down during that same period of time. So there's something going on here in the United States that we need to be paying extra careful attention to try to understand what are those drivers. Some of the other demographic characteristics of note, I think, just to help people get a handle on some of those differences. Rates of suicide tend to be higher among men than women, on the order of 3.5 to 4 times more common, whereas attempted suicide tends to be that much more common among women than men. There are differences in rates geographically, where they tend, in general, to increase across the United States from the East Coast to peaks in the Intermountain states, and then maybe drop a little bit after that. But those rates can vary tremendously from state to state or locale to locale. And then subgroups of the population by age, and I mentioned that, by race and ethnicity, in which rates overall tend to be higher among the white population than non-white, but with some of the highest rates, for example, being among American Indian, Native American populations and men in those groups in particular. So it's I would also add, I think, important to understand for epidemiologic purposes and for prevention purposes to understand these differences, because we can learn a lot about that as we observe their change over time.
Absolutely.
But it's also just to say they are group numbers, and that's a little different than how we approach the individual who's sitting across the chair from us, where we're taking a different kind of approach to assessing risk.
And speaking of the individual, what do we know about risk factors? Is it possible to identify people most at risk of attempting suicide?
Well, certainly we have a series of risk factors that we look at when we're assessing a person sitting in front of us. And it can be as much as, access to lethal means. Guns overwhelmingly are the means that people use in killing themselves. And so access to weapons, access to fatal medications, these kinds of things. History of suicide attempts also tells us that there's a risk of another suicide attempt. History of suicide in the family poses another risk factor. Recency or exposure to suicide in the media or a friend poses another risk. And so these might be clearer ones to identify. And then there are things like mood disorders, depression. Depression and suicide often travel together, right? Not necessarily always, and much. Family history of violence or abuse, sexual abuse, emotional abuse, verbal abuse. Substance abuse problems, as I think you mentioned, like these things are risk factors that we want to take seriously because of the ways it intersects with the mood disorders, potential means access. And we want to make sure that these are things we're paying attention to and potentially problem solving. What we see, especially in teens and young adults, is the experience of being bullied or cyberbullied. And we can talk about the specifics regarding teens and young adults perhaps later, but that creates a vulnerability for kids who are then ostracized from their community and are often attacked in ways of their burgeoning identity in a way that really impacts their risk.
It's one of our goals for this session today is to weave in as many audience questions as we can. And we're getting a lot of questions for you, too. A viewer says, please talk about the relationship between chronic illness or pain and suicidality.
If I could take that in a slightly larger context and then focus down, it would be helpful, I think.
Sure.
When I talk about suicide risk in older adults, I use a tool that I call the 5 Ds to just facilitate how individuals and clinicians try to manage the sometimes complex combination of factors that contribute to suicide risk. And I mentioned depression. And that is a real driver, but so are other psychiatric illnesses and addictions and others. So we can come back to that as well. Disease, second D, which we'll get to this question. I'll come back to that very shortly. And disability, which is functional impairment, which can be due to a variety of different conditions. So depression, disease, disability, disconnectedness, and we can talk more about the powerful importance of being connected to other people in a meaningful way for the individual, and then access to deadly means, D, the number 5, which Anna mentioned as well. Coming back to the physical illness, the second D that I mentioned, and it's closely related to the third, of dysfunction as well. Yes, we know that from evidence from studies that the presence of a physical illness will increase risk for suicide independent of other factors. That increase is relatively small, on the order of, in studies, 2 times increased risk for illnesses like cancer, most cancers, neurological conditions, and some others. But that's in contrast to the relative contribution or relative increased risk associated with depression, clinical depression, for example, which might be, studies suggest, maybe 40 times higher. So it's real, the physical illness, but not contributing as much as psychiatric illness. And let me get back to the other really important point that Anna made, which is that these factors don't operate alone. One of the other myths, just to tie it to a previous conversation we were having, is that it's a simple matter. It's a response to a problem. I see that so often, unfortunately, in some of the work that we've done with people who have taken their own lives, that those around them tend to ascribe it to a particular problem. He killed himself because he had cancer, or because she killed herself because she was bereaved by the loss of a spouse. It doesn't work that way. These things overlap, as Anna was saying. So that I picture those 5 Ds as a Venn diagram in which each of those domains overlaps and interacts with the others. So an older man who is physically ill, has the cancer, that increases the risk, maybe 2 times higher. But if that older man also, because of that cancer, has functional impairment so that he can no longer drive, or he's having trouble walking, getting out of the house, that's another compounding factor. If on that basis he becomes disconnected, that third D, then losing the supports from people around him further increases the risk. And if he becomes depressed, all of those things, by the way, contribute to and are risk factors for clinical depression, then that combination of those 4 Ds really is increasing the likelihood or the concern about his taking his own life. And then if he's got a firearm in the closet, if he's got a handgun in the bedside table, then this is a person who's at even greater risk. And it's that kind of inquiry about the fact going on across these different domains in an individual's life that enables us to get a more and more refined idea about some of the contributing factors and therefore opportunities to intervene that an individual might be facing.
Before we move forward from the risk factors portion of this conversation, I do want to work in one more audience question. When is something that looks like non-suicidal self-injury related to suicidality, and when is it separate factor unrelated to suicide risk?
When is it separate and when is it related? It's sometimes hard to tease out because these things often travel together too. People who tend to cut themselves, burn themselves, hit objects as a way to regulate their emotions and kind of get some relief from the internal pain may at other points have suicidal thoughts or take suicidal actions. And these can be distinct things. So when I have somebody in front of me who has perhaps cut themselves quite severely, this is something I want to ask about. What was the thinking? What were the emotions? What was the intent in taking this action? And to piece it out, because I work with young adults who do struggle with both, and one day might have suicidal intention when they cut themselves, and another day may not. It's just in the service of emotion regulation. So I think it's in the assessment.
Let me ask, go ahead, Yeates.
If we might expand that conversation a little bit, because it's a great question, and that Anna, you're gonna see a lot more NSSI than I do in an older adult population, because it's so much more common in kids. One thing that we do see a lot of in the adult and older adult population is what might be called indirect suicidal thoughts or passive suicidal thoughts. Somebody who isn't recognized to be suicidal, but that they're, I don't know, taking extra risks that might put them in harm's way, or not taking their medications in an older adult in a long-term care facility, for example. And deep down, that may be behavior driven by some intent to harm oneself, but it's not necessarily in their awareness, and they don't conceive of it or talk about it that way. So some of these boundaries are really important to, as you're saying, bear down on and try to help them begin to tease out what is the intent behind it.
I want to talk both about signs and symptoms and formal assessment. Let's start with some of those red flags, if you will. Do most people who attempt suicide give some warning signs about their intent?
Absolutely. And some of them can be as clear as a person saying, I want to kill myself, right? Or they're writing suicide notes and giving them to family members, right? They're communicating it directly and clearly. Or maybe it's a little less direct, I'm not going to be here much longer, things like that. Or I'm not going to have to worry about this problem much longer. Those kinds of communications, absolutely, we have to take seriously. And those are the ones that are perhaps most clear. Other signs can include things like significant changes in appetite and in sleep, which again is tricky with some of the adolescents that I work with whose sleep habits and maybe their dietary practices aren't exactly on point. And significant changes is a big warning sign for the kid who is sleeping all day, the adult that is suddenly reporting not being hungry and not eating at all for long stretches of time. We see loss of interest and engagement with typical activities that they've previously been engaged in. So it's the people who are no longer going to book club, right? Aren't going to their pickup basketball game, aren't in the activities socially. They're withdrawing from these kinds of things. We tend to see increased alcohol and drug use. And this is something we, again, want to pay close attention to and assess. And giving away possessions, these kind of indicators. And as Yeates was saying, sometimes it's increased risky or impulsive behaviors. For other people, it might be an unusual spike in irritability that might be secondary to some of this kind of hopelessness that people are experiencing.
So important to put these out there. Yeates, do you have other warning signs that you want to include?
Well, I think that covers it really, really very well. That the hopelessness actually is very telling. I mean, there's a sense that hopelessness actually is more predictive of subsequent suicidal behavior than, for example, depression might be. Another thing one often sees in the older adult population are signs and symptoms that don't look typical for depression, and therefore, in some segment, those who might go on to be suicidal. but rather more somatic complaints, as we call them, complaints about headaches or gastrointestinal problems or lack of energy, as opposed to feeling sad or guilty. But the hopelessness tends to shine through. It won't get better. Another, perhaps a warning sign, I think it is, and it's so important to recognize, is a sense of being a burden on other people. Life isn't worth living, both because of the person's internal pain and struggle, but also because of the concern that they might be harming other people by being a burden, and therefore, by ending their own lives, they're actually helping other people. So there's a kind of distortion in the thinking that often comes with a suicidal crisis.
Well, and I think too, like the hopelessness, when I interact with people who are so stuck in suicidal thinking, there's this feeling of being trapped. And I think another myth can be that people who have suicidal thoughts want to die. And when I'm working with somebody, I try to reframe it as you want to solve a problem. And the problem is maybe the pain that you're in response to any number of the things that we've been talking about today. Overwhelming pain, and you want to solve it. And this is where your brain is going to as a solution. Let's open up options. Let's see if we can flex things, because there are other ways to solve the problem of, you lost your job and your wife left you and you're about to lose your house. Let's focus on that problem, and let's focus on the emotions without that as the only solution that somebody sees.
Such an important point. Yeates, you've got your hand up. Something else you want to share?
I did. I'm thinking to some of the things that I find most helpful in understanding, kind of creating an empathic understanding of the suicidal state when I'm talking to trainees of various kinds. And they come from a guy named Ed Schneidman, who was a suicidologist, one of the founders of this notion of the study of suicide, and kind of a colorful guy. But he had a way of boiling things down to some really basic constructs that are so useful. Three of them that I remember are of a larger group that he calls commonalities of suicide, and they're ambivalence, cognitive constriction, and intolerable pain. So he would say every suicidal person has these things. Every suicidal person has a source of intolerable pain, typically psychological, that we need to understand if we are to become helpful. Ambivalence, and this is what reminded me, because you mentioned that so clearly, Anna, is that every suicidal person is ambivalent. They may want to die, but they also want to live. It's a question of where that balance can be struck. And it changes potentially very easily and quickly from a wish to live to relatively more of a wish to die. And that's the dangerous state. The good news in there is that other potentially simple interventions can change that balance, even if only for a moment or an hour or a day. But that would give us the opportunity to build on that positive side of the ambivalence, that I want to live. I just don't know how. We can work on that. And the third is the notion of cognitive constriction. And that's the idea that in the suicidal state, people really lose the ability to think flexibly and creatively about how to relieve that intolerable suffering that they have. And that's a dangerous situation. So part of what we need to do is recognize that Schneidman would say things like, you should never kill yourself when you're suicidal, because you don't have the cognitive flexibility to find solutions. So it lends the notion to us as helping professionals that if we can help that person broaden those blinders that they have on about their options just a little bit, they will begin to become more flexible and be able to find solutions that do shift them from that drive to end their life to a reimagining of what the positive side of that ambivalence is about, where that's coming from, and why there might be reasons to live.
Yeah, to think longer term, right? I have felt differently in the past. I may feel differently in the future, right? I can solve this problem again more flexibly, which is tougher for teenagers and young adults. And it's tougher for them to maybe think longer term just because their prefrontal cortex hasn't quite developed enough. And so in that moment to really push on that. Exactly.
Mm-hmm. And at the other end of the life course, the idea that the stigma of aging. So yeah, I can't change it. I'm sick. I'm not functional the way I was. The reality is, of course, that people in middle age and into older adulthood tend to be in general, on average, more satisfied with their lives than people at younger ages. So the disconnect between what is real and what is a reflection of hopelessness, cognitive constriction, in an inability to think alternatively about how their life might work is really where the action is, I think.
We're going to circle back to suicide prevention. Obviously, it's such an important topic in just a few minutes here. I do want to ask you about assessment, though. Given the warning signs that you've spelled out for us here, we often hear about risk assessment tools and efforts. Can you kind of walk us through from a professional standpoint how assessment is done?
Well, I mean, the two biggest ones that I think are used in systems across the country are the Columbia Suicide Severity Screening Tool, which gets into the specific questions of, what is the risk? What is the plan? There's also the ASQ, which is the Ask Suicidal Screening Questions, which is quite brief. And it then outlines this person's at risk. Okay, we need to take a second step. There are other screening tools that are used in primary care settings all over the country, the PHQ. It's more about depression, less about suicide specifically. And it can be a good way to identify maybe who's really struggling and then take that next step. But doing those kind of formal assessments has been shown up and down and around the block to be incredibly helpful at identifying the people who really need that next level of intervention.
Yes, I might build a little bit on that with regard to the setting in which one is doing that assessment, because they're going to vary. And with regard to primary care, for example, the PHQ-9 is depression focused. It's probably the dominant screening tool, however, used in primary care settings, which are such an important part of our network for detecting suicide risk and intervening. And there's controversy there. The PHQ-9 takes 5 minutes or less to administer, and yet in that setting, it's a very busy place where the average time that a primary care doctor has with a patient is somewhere between 9 and 15 minutes or something. So there's a disincentive compounded by some very controversial recommendations in some respects. The U.S. Preventive Services Task Force, which has said it's not justified to do universal screening for suicide in primary care practice. Whereas I think most of us would agree that it's easy and really important to do, or you may miss it. The PHQ-9 problem, of course, is that ninth question, which is the suicide one, is pretty non-specific. It says, have you in the last 2 weeks had thoughts that you'd be better off dead or of harming yourself in some way? That's a pretty broad set of questions. And what tends to happen in primary care then is that the PHQ-9 because of the time constraints, gets squished into just the PHQ-2, the first two questions of it, and they don't ask that. And so we're going to miss people. But the context is so important, and helping educate and provide primary care providers and offices with other kinds of resources to draw on. That's going to be different than how suicide gets assessed in a school setting or in a clinician's office or some other places. So there are a lot of different tools out there. And the question is how to help the providers or the systems make informed choices and understand the importance of then fitting them into their workflow so that they are routinely utilized and in a skilled way. I guess the other thing I'd mention is, this isn't rocket science. I mean, you can get down there. There's good evidence that simply asking somebody if they've had thoughts of ending their life gets you a long way to identifying people at risk.
Let me work in a couple more of our audience questions at this juncture. Anna, you mentioned bullying earlier, and a viewer would like you to talk a little bit more about the relationship between bullying in teens and suicide.
Sure. Adolescence is such a dynamic and exciting time of change, right? In so many ways, as bodies are changing, as emotions are changing, as kids are figuring out their identity, and they're starting to lean increasingly on peer relationships and less on the parental relationships, the family relationships. And those peer relationships take on such profound meaning during the time of adolescence, that kids really start to figure out who they are in relationship to one another. And it's crucial. And it can be a source of tremendous support. And all of these factors, this dynamic and exciting time of adolescence, is also incredibly stressful and incredibly painful for so many people. And in those times, I mean, bullying has been around, forever, and the social piece starts to develop more conflict, more competition, more judgment, more drama, as the kids say, and factions start to divide up. And there are kids who are on the outside, who are disconnected, ostracized, and the loneliness then takes on such greater weight. Of course, it is painful and overwhelming at all points in age. But as Yeates was saying, it's during this period and later in elderly populations that it really carries much more force. And when a kid is disconnected, ostracized in that incredibly painful way, perhaps judged for who they are, and we see this particularly painfully with LGBTQ kids, whose suicide attempts, suicide risk has gone up significantly in recent years. And then we add the layer of the internet and social media, where bullying isn't just in the schoolyard or in the hallway, it's now 24/7. And it can happen in much more public, shaming, and targeted ways that is even more acutely painful to kids during this vulnerable time. And so their risk goes up, and we have to pay attention to the kids who are getting bullied.
Great point. And we are going to talk much more about that as well. So many important topics to cover here. Yeates, you touched upon passive suicidal thoughts. Can you speak more to this topic? This is a question from a viewer. Perhaps give us some examples and let us know when we should be concerned.
Great question. The difference is between active and passive suicidal thoughts, whether there is an intent to act. So typical passive suicidal statement might be, my life is no longer worth living, or I'd be so much better off if I simply died in my sleep, didn't wake up in the morning. as opposed to the active, which is I'm having thoughts of actually taking my own life. I'm having thoughts of killing myself. And then beyond that, this is the method that I'm considering using. So the notion of whether there is additional risk, if there's a difference between those two in the likelihood that somebody will go on to take their own life, that's a controversial area that again, probably differs based on age. It's not unusual. And I would say in a lot of people, not even atypical or abnormal, so to speak, for an older person to say, my life is no longer worth living. This is not the life that I had when I was younger. Have you had thoughts of taking your own life? No, I would never do that for different reasons. It might be obligations to my family or a concern that it would harm them in some way if I took my own life, or my spirituality, my religion would not allow me to do that. So that's off the table. And there's a passive suicidal thought there, but it's a different kind of risk than for that same older person if they're saying, and I've had thoughts about how I might go ahead and do it. So that's how we begin to make the assessment between what is a kind of suicidal thought or thought about death, even more broadly, and one that, and therefore maybe of less immediate concern than teasing out what in the thought patterns of somebody might be something we need to be more actively involved to sort through and base an intervention on. And so we do that based on those kinds of factors, the passive versus active nature of the ideation, the presence or less or absence or less well-formulated planning that might go along with it, and then on from there.
Well, and continuing to talk about it, because sometimes the passive thoughts can start to become less fleeting. They can get stickier, and then mood starts to drop, right? And then it can start to shift. And so continuing to ask about it for providers is important, to not dismiss them, that suicidal thoughts, even the passive ones, we have to keep talking about and understanding what does that sound like in your head?
Yeah. And that shades into the warning signs we were talking about before. Right. We need to understand where that fits in the person's life and how it's changing over time. Yeah, great point.
Another viewer question. How does exposure to or having a family history of suicide attempts affect one's risk of suicide? You touched on this earlier. Can you expound a little bit more on that?
Well, I think there is the quality. First of all, I mean, when somebody has lost a family member to suicide, there is the grief and the loss at baseline. Loss to suicide, as you're going to talk about later in this course, I think, is a particular kind of grieving and emotional fallout for a family. And so there's that as well. And then when people have seen people die by suicide, it's like it becomes more in the realm of what's possible. And I don't think it grants permission, but it does pave a pathway. And this, of course, then intertwines. Suicide is not hereditary. Like that is not the case. And mood disorders and depression can be, right? And so as people have seen and grieved and experienced the loss, however that might then impact their lives, paired with the exposure to the suicide, it does increase their risk.
Let me ask you this one, Yeates. We've had several questions come in from people or asking about people with histories of traumatic or adverse childhood events and how that impacts this conversation as well.
Sure. And I'd invite Anna to comment on this from the perspective of one who works with younger people. But it's very clear that when one encounters adversity in childhood, that the scars from that can be carried forward and manifest in a lot of different ways in adulthood, middle-aged, and even well into older adulthood. And one of those ways can be as a predisposition to the development of serious depressive illness, reemergence at later ages of stress response syndromes, post-traumatic stress disorder, and suicidal ideation, as well as other health impacts, biologically, predisposition to developing cognitive impairment, for example, or of diabetes and heart disease. It's a serious, I think, clearly underappreciated problem, which reinforces our need when we are looking to assess an older person's or middle-aged or younger adult person's risk, to understand where they're coming from. Where did it all begin? What was their experience of trauma earlier in life, and how might that be helping color their coping capacities in the face of later life stressors, which may trigger the reemergence of trauma and suicidal ideation.
And I'm going to point this one to you because you've been talking about some of the issues for school kids, for example, around bullying and whatnot. A viewer says there is fear in our school system that holding a workshop around suicide for our students could lead to some of them becoming at risk. Is there any truth to this thinking?
Well, I think this gets back to your first or second question, Jeff, of how we talk about suicide can steer how it's heard and then where it goes from there. And so we want to be incredibly thoughtful and talk about how open we are to thinking about this, that we're available, we're interested, we're curious. And we want to make sure that we're doing it in a way where we're outlining how complicated of an issue it is, that hope is possible, that help is here and available, right? Leaning heavily on those notes, I think, can make it more of a resource, but also to balance it with some education. But I think it's being mindful of one's population, particularly with young adults who can be vulnerable and susceptible depending on what the messaging is.
Yates, a question came in about the gender differences. Absolutely. Why don't you add that first, and then we'll move on to another topic.
Because it's an important issue that extends to something that relates to messaging more generally, and that I want to make sure we didn't miss today for people, and that is how the media manage their reporting on suicide, and it's reflected in also advice on how school systems might manage the suicidal act in their communities. But the advice, and it's based on very clear evidence on how contagion, that concern about actually suicide being contagious, has been shown in the media, and the guidelines there include advice for reporting on suicide that it not be sensationalized in any way, that it minimize any details about the method used or the process that went on prior to the death, and avoiding those terms in the discussion of suicide in a community that we talked about before, terms like committed suicide. Not publishing photographs of the scene or anything other than a respectful acknowledgement that there's been a loss in a community, and acknowledging that has impact on others around them, and then being prepared as a system to respond in a supportive way, but informed by the risk that is inherent in even sadly honoring the person who died by suicide. There's a way to do it, and there's a way not to do it.
Absolutely, yeah. Particularly when it comes to teenagers, right, who are so vulnerable in the wake of a completed suicide. But in terms of, I think, education, it absolutely makes sense. Like, put it out there for kids so that maybe you can assess who needs that support, and don't be afraid to talk about it. And the mindfulness of how we talk about it, what we emphasize, particularly with teenagers.
So important. The three of us are going to have a separate discussion about specific intervention strategies shortly. Right now, I want to focus on some of the broader initiatives that we can look at to help prevent suicides. What are some of those at a macro sense? Education and awareness, for example.
One of the ways I think is helpful to step back and structure our thinking about suicide and its prevention is terminology used by the Institute of Medicine initially, which is to think that there are preventive interventions, which they call indicated, which are targeted to those people who are at immediate elevated risk. Selective preventive intervention, which is interventions that are, so to speak, designed to prevent vulnerable people from becoming suicidal. And then the third, which maybe gets more specifically to the point that you're raising, are universal preventive interventions, those which, from a public health perspective, target populations irrespective of the risk of any individual within that population. I'm of a school that believes that those preventive interventions at all three levels, and perhaps even more than the selective and the universal preventive interventions, are critically important for us as communities and as a country to lower the overall burden of suicide and suicide morbidity.
And anything you want to add to that?
No, I think that's spot on.
Okay. Let me squeeze in a couple more viewer questions before we wrap up this session, because I do want to work them in here. A viewer would like to know a little bit more about some of the gender factors when it comes to suicide risk. You both touched on this along the way. What can you tell us a little bit more in depth about how gender factors into suicide risk?
Well, I think, Yeates, as you pointed out, that the suicide rate for men is 3 to 4 times greater than for women. And I think there are a lot of hypotheses for why that is. Their means tends to be weapons, right? Guns and more lethal means. And I think, and this might be an entirely separate conversation about men, emotions, help seeking, and being receptive to support in times of particular crisis and vulnerability. So I would start there, that it is so much higher for men. And when we talk about LGBTQ populations, when they're in unsupportive environments and they're feeling disconnected based on perhaps gender identity, that can put them more at risk too.
Yeates, you look like you have something you want to add to that.
Well, it's such an important and intriguing question. There's this notion of the social and cultural factors that contribute to suicide and suicide risk. And there are many that relate to race and ethnicity and spirituality, and gender is right up at the top. There's this notion of masculine scripts and feminine scripts. Men just, by and large, and this is cultural and geographic, don't establish the same kinds of strategies that women do. So while suicide rates are that much higher for men, suicide attempts are much higher for women. So it's not like that is not these scripts and the notion of masculinity and the comfort with guns and exposure to guns and the increased rates of alcohol and drug misuse, which reduce perhaps some of the coping abilities in an acute situation, intoxication. So there's an awful lot going on there. Men don't ask for help the same kind of way. There's that meme about, a man being kind of lost somewhere, and is he going to stop and ask for directions? He's just going to wander around until he finds something that looks familiar, and then go find his destination. So we have culturally determined problems in that, and gets back to this notion of what is then a potentially universal preventive intervention, notion about how we can speak to men in a different kind of vocabulary that says, it's okay to ask for help. It's not a masculine thing to struggle on your own. In fact, it takes some real masculine strength to seek help, to recognize when you need help from other people. So that would be an example, I think, of a messaging intervention, that one of many that we could potentially take that targets a particular aspect of the risk determination based on gender.
And one more question involving borderline personality disorder and self-harm, as well as suicidality. Anna, this is an area that you've worked in. Would you help us understand, as briefly as you can, what borderline personality disorder is, and talk about how often those with BPD are self-harming and experiencing suicidal ideation?
Well, self-harm and suicidal ideation are two of the diagnostic criteria in the list for diagnosing borderline personality disorder. So they are in there, those kinds of behaviors, paired with emotion dysregulation and impulsivity and some of the relationship aspects as well. And so I would say almost the majority of people that I work with borderline personality disorder do have some non-suicidal self-injurious behaviors, and often have suicidal thoughts as well. Okay, these two things do not borderline personality disorder make, right? That people can be struggling with all kinds of other diagnoses or issues in their life and not meet the criteria for borderline personality disorder. And these are part of BPD. And I just want to say, in terms of hope, BPD is treatable. There are many options available, and people do get to the point where they're no longer diagnosed with BPD.
Great. Thank you. Yeates and Anna, I think this is probably a good place for us to wrap up this particular overview of suicidality. Of course, we want to drive home the importance of helping someone who is struggling and remind folks that there are great suicide prevention resources widely available.